and welcome to Economic Solutions. We have what we think is a very fulfilling program today. We are guesting Professor Gerald Kominski from UCLA. He's a professor in the Department of Health Services and Director of Health Economics and Evaluation Research Program at UCLA, Center for Health Policy Research. Research and teaching include models for estimating health expenditures and forecasting population health. He is currently vice chair for the Financial Impact Analysis Team, which analyzes insurance mandates for the California Legislature's Health Benefits Review Program. He is co-editor of the widely used textbook, Changing the U.S. Healthcare System, Key Issues in Health Services Policy and Management, with the third edition published in 2007. So Jerry, welcome to Economic Solutions.
Thank you. It's my pleasure to be here today to talk to you about health reform and the need for health reform in the United States.
Right. This program is about the economics of healthcare, and your program is entitled The Case for Health Reform in the U.S.
Yes.
So you're going to present approaches that maybe not all of us are familiar with, but that we should be, and kind of hold our hand and guide us through the issues we're looking at. There's so much rhetoric and propaganda going on in the media. And remember, the function of our show is to inform. We try to be factual. We try to provide things that people can rely on or double check to make sure that we're not trying to provide anything that isn't soundly based. And so that's why I'm really thrilled to have you here. I consider you one of the great authorities in Southern California on healthcare, not just in the United States, but comparatively with other countries. So with that...
Thank you. So what I'd like to do today is I sort of have three parts to the presentation and to the talk that I'm going to lead you through. And the first part, I want to give some background about the current U.S. healthcare system, how we got to where we are, and what we spend our money on, where we are. The second part, I'd like to focus a little bit on comparing the United States with other European nations and talk about how much we spend relative to other countries and sort of some of the issues related to relative performance of the U.S. healthcare system and our health compared to other nations. And then finally, what I'd like to do is talk about the elements of the current reform proposal that's working its way through the House. What is the current health insurance coverage of Americans? The latest data is from 2007, and basically what it shows is that roughly 2/3 of Americans have private health insurance. And that's broken down into two major groups, employment-based insurance and what's known as the individual or non-group market. The fact is that in the United States, since the 1930s, our primary form of health insurance has been based through our place of work. And as you can see here in the table, about 60% of Americans are employed through their place of work or their dependents of somebody who's covered at work. Another roughly 9% have health insurance through the individual market. And these are individuals who may work for a company that does not offer insurance, or they may be self-employed. So the point is that it's a relatively large share of the population, but much smaller in comparison.
What happened before the 1930s?
Well, before the 1930s, there was no health insurance in the United States. In fact, there were efforts starting in the early part of the 20th century to establish a form of national health insurance in the United States. And those efforts led up through the enactment of the Social Security Act of 1935 under Roosevelt's administration. But there was no health insurance. It wasn't until 1929 that we had the first health insurance, private, nonprofit insurance, and that was the Blue Cross plan. It was formed at Baylor University Hospital in Dallas, Texas, right about the time of the beginning of the Great Depression. And that idea of voluntary insurance for hospital care became so popular even during the Depression that Blue Cross plans and then the companion Blue Shield plans to cover physician expenses grew dramatically during the Great Depression, despite the fact that up to 25% of Americans were out of work. We had private insurance as the primary form of insurance in the United States from 1929 up until 1965. And what changed in 1965 is that although many Americans got their insurance through their place of work, the elderly were left behind. When throughout the 1940s and 1950s, for the most part, when people retired from their job, their health insurance benefits were terminated. And as a result, they were responsible for buying insurance on their own. Well, what this led to in the 1950s and the early 1960s is that roughly 50% of the elderly could not afford health insurance. And roughly a third of the elderly lived in poverty partly because of the high cost of health care. As a result, Congress enacted the Medicare and Medicaid programs in 1965. And as indicated in the slide, today roughly 27% of Americans receive coverage under one or the other, or in some cases under both of these programs. Some Americans qualify for both Medicare and Medicaid. 2 years ago, our best estimate was that roughly 46 million Americans were uninsured. As a result of the recession that we've been going through and the economic crisis over the last 18 months, this number now is probably closer to 51 million Americans. And this fact in and of itself represents one of the greatest reasons why we need reform of healthcare financing in the United States.
Now, how many without illegal aliens out of that 51 million?
The best estimate is that there are about 6 million undocumented immigrants in the United States who are uninsured. And to just address that issue up front, there's no provision for covering undocumented immigrants under the President's proposal for health care reform.
I see.
If you work for a large company, and here we define a large company as 200 or more employees, and that's indicated by the green upper line on this graph, you have basically virtually 100% probability or chance of being insured by your employer. It's at the other end of the spectrum where you're much less likely to be insured. So if you work for a company that's under 200 employees, you have about roughly a 62% chance of being insured as of 2008. And if you work for a really small company, fewer than 10 employees, you have roughly a 50% chance of being insured by your place of employment. So the fact that employers are not required to provide health insurance benefits to their workers is one of the major causes of the large number of uninsured Americans. And the data that we have indicates that roughly 80% of the uninsured in the United States are either working or a dependent of somebody who is working in a job that does not provide health insurance benefits.
They're just not eligible under what they're offered then by their companies.
They're not eligible because the company's just not offering the insurance. Or if it does offer, it's offering the insurance but is not contributing to the cost of the insurance. So in other words, it may offer a policy to its workers, but the worker is responsible for 100% of the premium. So specifically, the yellow bar on the far right indicates that people who buy their insurance in the individual or non-group market have a 1 in 4 chance of spending 14% or more of their total gross family income on health care. And that percentage of family income that they have a 1 in 4 chance of spending gets bigger and bigger as their family income declines.
Because the costs of the insurance remain the same. Apparently.
The cost of the insurance remain the same. We basically pay the same costs regardless of our income. The coverage that's affordable to lower income families typically covers a smaller portion of medical expenses, leaving the family at greater risk or having greater responsibility for paying costs out of pocket.
So they actually have less insurance coverage when you get over here to the left side of the
That's
screen.
exactly right.
But it's taking up more percentage of their income.
That's right.
Here, this yellow bar is what, 30.5%?
30% of family income. You have a 1 in 4 chance of spending more than 30% of your total income on healthcare expenditures if your income is in this category.
So that's almost a third. That's a third of my income if I make how much money?
in that category, 100 to 200% of poverty, for a family of four, that represents a very small amount of money. It represents roughly between $21,000 and $42,000.
So if I were a family of four, I had $42,000 maximum income. I could spend at least a third of my income for health care, and even that would be reduced from what the norm is, you might say.
That's exactly right. It's very difficult to buy an insurance policy for less family coverage for less than $12,000 a year. And $12,000 is a substantial portion of family income when you're making $42,000 a year.
Right. That's sobering.
It's widely known that we spend roughly now about $2.2 trillion a year on healthcare in the United States, representing approximately 16.2% of our gross domestic product. Per capita, it's almost $7,500 per person for every American. So we're the only industrialized nation where the majority of financing comes from private sources, and I'll show you a slide that compares us to other countries in a few moments.
Are you going to tell us why that is?
Well, it's largely because of what we were discussing just a moment ago, which is that the history of the United States and the evolution of health insurance in the United States was private employment-based insurance. And that is still the basis of our insurance in the United States. And that is a historical, that is the way health insurance evolved.
Compared with other countries that are different? Did they evolve differently than
They did evolve differently, and many European countries decided either a century ago or during mid-century, during the mid-20th century, that public financing of healthcare was the appropriate way, not private markets, to pay for health care for all citizens.
Well, we're going to be very interested on this show to see how these other countries fared compared to us. You know, are we on the right track? Are they on the right track? Is it some combination of the two? And of course, I'm oversimplifying because I know there are several different types of hybrid systems among nations.
The largest public program in the United States, the largest public health insurance program, is the Medicare program, which has been in place since 1965, covers virtually all elderly and a substantial portion of disabled individuals in the United States. And Medicare consists now of four parts. Medicare Part A and Part B were the two original pieces of Medicare when it was enacted in 1965. And Medicare Part A is primarily hospital insurance and other facility-based care, institutional-based care.
Now, government does not own those facilities under Medicare, right?
No, not at all. The Medicare system and the Medicare program was a public financing program that was built on a privately owned and operated system of healthcare delivery. And that is the public model that was developed 45 years ago at enactment of Medicare and is still in operation today.
So that is public health care provided for in terms of financing by the government, but it's into the private sector.
That is correct.
So we're going to get into this a little more in the program later to define what a socialistic system is, which is different from this.
Absolutely.
This is not a socialistic system. This is what we will call a civic capitalistic system where public money is channeled into the private sector for providing and delivering these services.
That's right, and we've had the system for going on close to 45 years now. Medicare Part A and Part B, and Part B is the basically coverage for physician services, but A and B represent the original traditional Medicare program, and it's fee-for-service medicine. People choose their doctors, they go to the hospital, Medicare pays the bills on a fee-for-service basis for the most part. There's a lot of choice, there's broad participation among doctors and hospitals, and this is the program that was enacted in 1965. Since then, Medicare has evolved into a managed care component which combines A and B together, into something called Medicare Part C and allows the elderly to join HMOs. And then more recently, Medicare enacted a prescription drug benefit, which is Medicare Part D, and is now almost 10% of Medicare expenditures. But we're spending close to $500 billion a year now under the Medicare program. I also wanted to, just for a moment, talk about the Medicaid program, which is originally the program for low-income families and individuals, also enacted at the same time by Congress in 1965, that same time as Medicare was enacted. The Medicaid program provides very valuable coverage to low-income individuals, but not everyone qualifies.
Do you know what percentage of people that should be eligible are disqualified?
The best estimates now are that there's somewhere on the order of between 10 and 15 million Americans who would qualify for Medicaid if there was a single uniform standard across all the states with regard to income. Now, one of the facts of the U.S. healthcare system, and this is sort of, I think, another fact that is often misinterpreted or not widely understood. If we look at this slide, there are basically two things that I want to focus on. One is, if we just pick, for example, the top 5%, the top 5% of users of healthcare services in the United States account for 50% of total expenses. So we're talking about 5% of the population in any given year accounting for 50% of our total expenditures.
Are these people more ill, or what is the story?
It's a combination of two. There are two sort of populations there. One are people who are year in and year out high users of healthcare, primarily because of chronic or debilitating illnesses. And the second group consists of people who have an acute episode that may or may not be successfully resolved, but they are generally a healthy population who then becomes hospitalized because of an acute event. And we know that acute care hospitalization is one of the most expensive components of healthcare.
I think so far you've described some situations that are special to the United States, others that are kind of universal anywhere.
Right.
But let's see how other countries are doing compared to us, or how we're doing compared to them.
Zane, let me just make one final point, though, about the concentration, because this is not unique to the United States. But what is unique to the United States is that because we rely on private markets to provide health insurance, this kind of concentration allows risk segmentation. In a national system, this distribution is not a problem because the government is financing all health care. In a competitive market that relies largely on private insurers, this kind of distribution or maldistribution of expenses and users of health care provide a very strong incentive to avoid the high-cost patients and focus on the large percentage of the population that are relatively low users.
So therefore, if I am in the healthcare provider industry or in the insurance industry, and I am a risk management specialist, I can look at that segment there and say, oh, well, you know, these are very expensive people to cover, and I want to avoid them. I mean, I want to concentrate in these other areas.
That's the point. That's exactly the point.
So if I'm doing risk management, I'm getting paid to not cover those other folks. I mean, if that's how I'm going to look at it.
That's exactly right. And if you can sort of keep these high spenders out of your insurance pool, then you can focus on the more profitable portion of the population.
I'll maximize my profit.
Correct.
Sure. Okay.
Well, now let's transition, as you said, to looking at how the United States compares with other nations around the world, and primarily in European nations. And what this graph shows is the United States is on the far left here, and there's no irony in that. But the United States, if we look at the three components of the bars in these charts, the dark blue bottom portion represents the public spending by each nation on a per capita basis for health care in that country. And you can see that the United States, the dark blue portion, is still larger than any other nation's dark blue portion. And in fact, our public spending alone exceeds the total spending of some other countries like Japan and New
It
Zealand.
looks like we're higher than everybody. We're already high in the public sector, but our total, when you add the private,
Is almost twice any other nation. And that's largely because of both our large private market and the large amount of out-of-pocket expenditures that we make for healthcare in the United States. You can see in this graph that for this year, 2004, where the comparative data were available, on average, we were spending $803 per person out of pocket. There are many nations in the world that don't spend $830 or $803 per capita in total for
Yeah.
healthcare.
and I see we're at around $6,000 per year per person, and everybody else is close to $3,000 or even lower.
Correct.
And this is, you've got, 9 countries here, including the United States, I believe. And we are so expensive. We're very expensive. Can we move on to a little more? And,
Yeah, this raises obviously the question of, if we're spending so much, what are we getting for our dollar? Well, the next chart shows two other ways of comparing what the U.S. spends relative to other countries. And so in this chart, there are actually side-by-side graphs. If we look over on to my left, total expenditures on healthcare as a percentage of our gross domestic product. And you can see the United States is the top line. It's in light blue.
Yeah.
And the data here go back to 1980. We were still essentially higher than everyone at that time, with maybe one exception.
Whoever
it looks like
the red one was Germany. We were about the same as Germany.
But look at how our growth in healthcare expenditures as a percentage of our total economy, and it's been really two sort of growth spurts in here with a level period during the mid-90s. We've just grown at a much more rapid pace over the last 3 decades.
But Jerry, to me, what this says to me as a businessman is that we're not competitive. This is not looking competitive on the world market with regard to healthcare services.
If you think about healthcare as one of the costs of production for American goods and services that are potentially exportable, this means that there's a component of cost that are beyond the control of the manager of any firm, any company. And in markets where we compete internationally, this is clearly a disadvantage.
Okay.
Now, focusing for a moment on sort of health outcomes and sort of how well are we doing with regard to the overall quality and performance of our healthcare system.
What am I getting for my dollar?
Right, what are we getting? This slide shows, again, there's a lot of information here, but let's just focus for a moment on the two extremes. On my far left is France, and on my far right is the United States. And what we have in this slide is a display of the conditions that are described by the research community and by clinical researchers as medical conditions that, if they're appropriately handled by the healthcare system, can dramatically reduce mortality. So these are conditions that have been identified and widely accepted as where the healthcare system can make a big difference. These are largely cardiovascular diseases, but also include, for example, diabetes. And what you see here is that France, the mortality rate from conditions that are amenable to appropriate intervention are roughly, in 2002 and 2003, roughly 65 deaths per 100,000 population, whereas the United States is almost twice that rate.
Now, what does this 76 for France mean here in the white?
The white bars show earlier data from the time period 1997 and 1998. So this graph shows both where these countries were almost 10 years ago and how much improvement was demonstrated over roughly a 5-year period in reducing mortality. And you can see the good news is that everyone is showing improvement over a 5-year period. And that's something to be pleased with.
Except France is 65 deaths. that could have been prevented by healthcare, you might say healthcare intervention.
Correct.
And we have 110 deaths.
110.
Yeah. So, and all these other countries, Japan, Australia, Spain, Italy, Canada, Norway, Netherlands, Sweden, Greece, Austria, Germany, Finland, New Zealand, Denmark, UK, Ireland, Portugal. Wow. And we are the worst of all of those in terms of preventing deaths.
That is
due
correct.
to healthcare.
That is
inadequate
correct.
Healthcare. Okay.
And again, this does not cover all healthcare conditions, but this is the deaths included in this represent approximately a quarter of all of the possible causes of death. But it's the portion where clinicians have agreed that the healthcare system can make a difference.
So we spend double what everybody else does here. And if I took the middle of this somewhere, like 82 or 84,
Right.
And that would be, it looks like Sweden or Greece,
Right.
yeah. But we're 110 compared to 84, and we're spending double of these countries.
That's
and
correct.
We're losing more people.
That's correct.
Per amount spent and per intervention. Okay.
That's correct.
Okay.
Now, the next slide just illustrates a point that I think is maybe widely known, and that is that the proportion of Americans who report having access to care problems as a result of the cost of health care is substantially higher than most other nations. You can see that in the Netherlands and the UK that the proportion that represent cost as an access barrier is very, very small. Canada, it's still relatively small. Germany, not so small. It's a little surprising. New Zealand and Australia, also roughly a quarter. But in the United States, in 2007, 37% of adults who had reported having some access problem related to cost over the past 3-year period.
So again, we're way higher than these other countries generally, and Germany even, which is 21 compared to our 37. We're spending double. More of our people die than theirs relatively, and we have more trouble getting access to care than those folks do.
Exactly.
Okay.
Now, one final point about the performance of our healthcare system, and that is and this is just an example that I decided to pick out. There are many others that we could have focused on, but there's a lot of talk now about innovation and about the use of electronic medical records in the United States. It's part of the stimulus package. And what we see is that the United States, again, lags woefully behind a lot of other nations in the percentage of doctors, primary care physicians, who report being able to use electronic medical records. In 2006, when this survey was done, 28% of doctors surveyed in the U.S. said that they had access to an electronic medical record. Compare that with the Netherlands, New Zealand, the UK. These are nations where there's been a commitment at the national level to develop electronic systems. And again, these are national systems where the issues of competing standards among different insurers is not an issue because there is a national system of financing care.
Okay, so again, we're way behind and we're spending double. Okay.
So that leads us to proposed reform. And so now I'd like to shift gears and say, let's talk a little bit about what are the details of the proposed reform of healthcare financing in the United States. What's actually in the bills and what can we expect? And what are some of the concerns that have been raised? So in no particular order, let's just talk about some of the elements of House Resolution 3200, which is the America's Affordable Health Choices Act of 2009. Now, I'm talking about the House bill today because the Senate still hasn't finished its work. Senate Finance Committee, when it comes back from recess, is supposed to finish working out the details, and then there'll be a complete Senate bill. So in the meantime, we have sort of the outline, and one Senate committee has done its work, but until Finance finishes its piece, we don't know the details. But we do, the House has finished earlier. And there are not major differences between the two approaches. But what are some of the elements of the reform proposal? Well, one is that it will require all individuals to have insurance. So it is an individual mandate. People without coverage will have to pay a penalty, and it will be assessed by the IRS. And it will be tied to their modified adjusted gross income.
Now, will everybody have to pay for this care under this plan? Or are there floors where people don't pay and will have the coverage anyway?
Well, I'm going to show you in a moment what the subsidies will be available. So in other words, this is not an unfunded mandate.
Yeah.
The mandate to have insurance is coupled with subsidies for lower income families and individuals to purchase insurance.
I see.
As well as an expansion of existing government programs, specifically Medicaid, to cover a broader pool of individuals.
But none of those government programs actually own the delivery systems as such. Is that correct?
That is absolutely correct. Nothing will change in terms of the ownership and the fact that our healthcare delivery system is a private system. None of that changes. This is healthcare financing reform. It's providing the subsidies necessary for individuals and families to afford insurance, along with the requirement that everybody be insured. So it goes hand in hand. It will require employers to either provide coverage or to pay into a health insurance exchange. Now, this is broadly known as an employer mandate. So we have individual mandates on every American and an employer mandate. And as I showed you earlier, right now, if you work for a company that has 200 or more employees, you're virtually assured of having health insurance coverage. It's the smaller employers. And smaller employers represent about a third of the employed. In other words, about a third of employed Americans work for smaller companies.
So, smaller companies today don't have a lot of buying power when they want to purchase healthcare services
That's
or
correct.
insurance. So the idea of the exchange is you collect all of these small companies together and they have more buying clout, I guess, when they go to purchase, right?
That's exactly
And they get
right.
lower costs. That's the
exactly
theory, right?
That's exactly right. The small group market is more expensive than the large group market because insurers are selling to small companies. It's a very small risk pool. There are more transactions costs associated with that. What this proposal will do is create an exchange to pool all of those small buyers and reduce the cost of administration. I earlier said the big was defined as 200 or more. I looked at the Bureau of Labor Statistics data. 2/3 of Americans work in companies that have at least 100 employees.
Oh, okay.
So it's
that
about
would be
a third.
classified as
It's still
that's
large.
big.
That's still
big,
large.
yeah. So therefore, you're talking about a third.
About
who
a
are for
third.
the smaller companies that are less than 100. Is that the idea?
That's correct.
I see.
And as we discussed earlier, you have about a 2/3 chance, about a 62% chance of being insured if you work for a small company, which means that roughly a third of Americans work for small companies, and roughly a third of those people are uninsured through their place of work.
So if I work for a small company, I have a 38% chance of not being covered by the company.
That's correct. And if you work for a really small company, you have a 50% chance of being uninsured. Another key component that I referred to just a moment ago is that the health reform proposals working their way through Congress would expand the Medicaid program to a national standard of 133% of the federal poverty level. And it would do away with what's known as all of the categorical eligibility criteria. In other words, if you can document that your income is 133% or less of the federal, you would qualify. You wouldn't need all of these other eligibility requirements that are currently part of the system.
And again, how much is that poverty level?
Well, 100% of poverty, right now the poverty level for a family of four is about $22,000.
Okay.
So 133% for a family of 4 would be roughly about $28,000 a year.
Okay.
What else would health reform do? It would create what's known as the insurance exchange, to pool, basically to replace the individual and small group market and allow employers and individuals to purchase health insurance that will be less expensive than insurance that's currently available.
And still delivered by the private sector.
That's correct. There will be subsidies to purchase insurance, and what I've shown here in this slide is one proposed subsidy scheme that's in the House bill. This is, of course, subject to change, but currently this is one schedule that's being proposed, and you can see everybody below 133% of poverty level would be eligible for Medicaid, so they would not get the subsidy, but they would get free care. There would be no payment to join Medicaid. As your income increases up to 400% of the federal poverty level, the amount that you pay as a premium would be tied to a percent of your income. And it would increase up to a maximum of 12% for people who are in the highest eligible bracket.
And I'm thinking of an earlier slide you showed that if you're in the poverty level at this point, you pay up to 30.5%.
You could pay up to 30%. You had a 1 in 4 chance of paying 30% of your total income in health care. This would substantially reduce the out-of-pocket liability that individuals would have at the lowest end of the income.
It looks like about a third of what I would be spending now if I were in the lower income ranges.
It's a substantial reduction.
See, because here you've got 11%. Here you had 30% in that other poverty level.
That's
here, this
correct.
Is 10 or 11. And this is one of the higher levels here of income, and that's only a third of what you showed. If I were, I forget what the percentage was of poverty, but I was going to pay over 30% of my income.
Yeah, it was actually in the
Healthcare.
lowest level, so it was for people down in these categories where they'll be capped at no more than 5.5% of their total income, whereas now they could potentially pay as much as 30% or more of their total income.
So that's like 1/6 of what they're paying now.
That's correct.
1/5 to 1/6.
That's correct.
Okay.
So there's still a sense of first of all, there's an individual mandate and there's individual responsibility. It's people at the very lowest end of the income distribution who are getting full subsidies, but for people at this end, still low income, they're still paying. It's not 100% subsidized.
Right. Okay.
Well, another key element of healthcare reform is that it will impose new regulations on plans participating in the exchange and in the small group market. And I say here, and in the small group market, because there's still, I think, some uncertainty about whether the exchange will be the only place authorized to sell insurance, or whether it will be the only place where that's eligible for subsidies. In other words, one view of the exchange is that it will replace all existing insurance, and that will be the only place that people can buy insurance.
And all the insurance providers would do business through the exchange.
That's correct.
Under that approach.
That's correct. The other vision is that the exchange will be where insurers who want to be able to qualify for subsidized customers participate, but there would still be the option for companies to sell insurance outside the exchange if anybody wanted to buy it outside the exchange.
Yes, okay.
And the regulations would actually get rid of some of the most egregious practices that are currently part of the small group and individual market. It would impose guaranteed issue and renewal of insurance policies, and it would not allow any exclusions for pre-existing conditions. It would limit the variation in premiums that companies could charge to only age, family status, or market area. So you would no longer be able to medically underwrite and charge people who were sicker or had more conditions
and charge them a higher premium.
You could only vary the premium based on the person's age and whether it's an individual policy or a family policy, and of course the area of the country in which they live. It would limit the non-medical care expenses of insurance companies and establish a certain payout, a minimum payout ratio, what's known as a medical loss ratio. And this number, as I understand, has been subject to a lot of negotiation, or at least possible negotiation over the last few days. But the idea here was to establish a benchmark for the insurance industry and say that for every dollar you take in as a premium, you must pay out some minimum amount in health care benefits.
Rather than for administration.
That's correct.
Because right now, I've experienced this myself. I feel like I am at odds with my insurance company. My insurance company is interested in maximizing their returns, their profits, and in therefore denying my claims. And they spend a lot of money in risk management and administration rather than providing the care.
Right.
They're spending an awful lot doing that, and I think that I just get an intuitive feel that that must be one reason that our costs in our country are double per person of other countries. There's an awful lot of insurance administration invested in our system right now. And so this approach that you're summarizing here apparently says, no, you're going to have to cut down on your administration and cut down on that cost or bureaucracy, if you will, and actually deliver the care.
And I think by doing away with pre-existing condition exclusions, requiring guaranteed issue and renewal of policies, it basically eliminates the need for doing all of this medical underwriting and constant scrutiny of individual patients and their health conditions, because the insurance industry will not be able to use that as a factor in setting premiums.
And the focus on that is not providing of care. The focus of that is denial.
That's exactly
It's denial
right.
of services.
That's exactly
and so
right.
I don't like to see money being spent on administration to deny me. I would rather see money being spent to care for me, or anybody really.
Exactly.
Okay.
So a few other key features that would provide tremendous protection for individuals and families is that in the exchange there'd be a limit on annual out-of-pocket liability. The limit would be $5,000 for individuals and $10,000 for families. This is actually a tremendous source of financial protection, because many health insurance policies now essentially do not have these annual limits on how much a family has to or can spend. And as a result, it's one of the reasons that we have so many bankruptcies in the United States, even among people who are insured, because these limits currently are not in place for many plans.
So therefore, a person's or family's insurance costs can go so high due to a crisis of some sort that will actually put us into poverty or bankruptcy.
That is absolutely correct. It's estimated that about 50% of personal bankruptcies in the United States are related to medical expenses, and many of those individuals are insured, but their insurance benefits run out because we don't have these kinds of guaranteed limits.
50%, half of the bankruptcies in the United States are due to health care crises that are unaffordable?
That is correct.
That's enormous. Okay.
The proposal for reform would eliminate lifetime benefits on, lifetime limits on benefits. So the condition that we just talked about would not be allowed, where you put a lifetime cap. And then finally, and perhaps one of the most controversial elements that's been getting a lot of press, is that in order to foster competition in the private sector, there's an option for a public option within the exchange that would be based on Medicare payment rates, and in a sense, its primary purpose would be to keep the private sector competitive and honest.
Okay, let's move on to the next display.
So this is actually the final slide, and actually summarizes, I think, some of the public concerns about healthcare reform that have been expressed. And
you put public in quotes.
I put it in quotes. And I put it in quotes because I wonder what public who the public is that's actually concerned about some of these issues. And I don't deny for a moment that there are real people throughout this country who have some of the concerns that are listed. But I also, given the nature and the intensity of opposition that's been mobilized in the last 3 to 4 weeks at town hall meetings across this country, I also wonder how much of these concerns have been staged for media presentation.
Okay, so we won't speculate on what that is, but all right, let's look at some of these points that are here, which look very valid to me. I'm satisfied with my health coverage, so why is a major reform necessary?
The best answer is contained in some of the slides that we talked about earlier. There are, first and foremost, there are major inequities in the current system of financing. About 60% of people in the United States are covered by employment-based insurance. And we know if you work for a large employer, you're fairly well covered.
Okay, now I'd like to comment on some of these points. Will it control costs? I think you've already explained what other countries are doing. So whatever they're doing, they're spending half of what we're spending. Their systems are working. We are a multicultural nation. We pride ourselves in capitalizing on input from all kinds of places. And if other countries are doing this, if my competitors are doing this, I think all Americans would agree that, hey, we can stand up and compete. And so I believe the cost control situation is certainly addressable by us. I don't see any reason that we cannot get out there and compete and deliver these things for the same cost. The next thing, which you have here, is it socialized medicine? I want to comment on that because I had a previous show on this.
Yes.
Socialism was defined by Karl Marx. It is the government ownership of all property and all means of production. That's what socialism is. It does exist in medical care in one country, the United Kingdom. They have socialized medicine. It is government ownership of the facilities, the delivery systems. That exists there. But the other countries you showed is not. They channel common resources through the government into the private sector, and they're doing it quite efficiently. So you only have socialism in England. The rest of them, not socialism. It's channeling civic capitalistic investments into the private sector for the delivery. Does it create unfair competition with private insurers? Well, I wanted to show a Business Week article here. The title of this article, which you can read from your perspective, is
Why Insurers Are Winning. And this is from this week's Business Week.
Actually, this was the issue of August 17th.
Okay.
So if this were true, Jerry, who is losing?
Well, I'm not sure that I agree with the premise, but let's say for the sake of discussion that Business Week has got it right and that the health insurers are gaining the upper hand in the debate over health care reform. In my opinion, based on the experience that we've had in the United States with the evolution of private insurance and then the need for public insurance to address what the private market doesn't address, if in fact private insurers are getting the upper hand in this debate, then the losers in this are going to be the taxpayers of America, because I think that without a public option under current reform proposals, that the U.S. healthcare system is going to be more expensive than it would be otherwise if we simply produce more government financing for private insurance.
All right, there's one final thing I want to show to our audience. I would recommend this book. It just came out. It's brand new. It's called The Healing of America, A Global Quest for Better, Cheaper, and Fairer Healthcare. It's by T.R. Reid, who is a Washington Post correspondent and former head of the Tokyo and London branches of the Washington Post. I recommend this book. We don't have time to go into it on this show, but I think anybody seriously interested should get this book from the library or buy it. You're going to see an awful lot that we have. Well, Jerry, we've come to the end of our time on the show. I think it's been very enlightening, though. You've presented a lot of information, a lot of it I haven't seen before in any of the major media, and I really appreciate your expertise and your thoroughness in all this. I want to thank you very much for being on the show. And we want to invite everybody watching to call in, let us know what you think about what you've seen here. We hope you are getting plenty out of the program, and we hope you'll look in on us next time.